Assalamu alaikum. Good evening, colleagues, ladies and gentlemen. Let me begin by thanking the organizers, particularly Professor Myth Nader Lessan, for inviting me, and also apologizing for not being with you in person this evening. The title of my talk, as you can see, is a question: CGM can reduce the fasting risk, true or myth? Well, here is the outline of my talk. Fasting risk, CGM, CGM as a behavior modification tool, CGM and Ramadan, and evidence that CGM can reduce fasting risk in Ramadan. What is the fasting risk? This audience would be quite familiar with this, and just as an example, but an important example, I'll just take you through this one slide from the DAR Global Survey published in 2022, and what I wanted to emphasize is the risk of hypoglycemia and hyperglycemia in this large study with over 12,000 participants, 14.9% hyperglycemia and 15.5% hypoglycemia. And going back a little bit further to 2010, the EPIDIAL study, which was a survey and compared the risk of hypo and hyperglycemia in type 1, type 2 diabetes before Ramadan and during Ramadan, showed that this risk was really quite significant, and compared to the pre-Ramadan period, the risk was several-fold higher. So hypoglycemia risk increased in type 1 diabetes 4.7-fold, hypoglycemia risk in type 2 diabetes 7.5-fold, hyperglycemia risk in type 1 diabetes 3.2-fold, and in type 2 diabetes 5-fold. So you're talking about several-fold increase in risk. And these are not CGM studies. And an important comparison would be comparing this to CGM studies that are more recent. So continuous glucose monitoring has become standard of care in type 1 diabetes and also in type 2 diabetes patients on insulin treatment in many countries, including the UAE, and those are the devices that we use commonly. CGM generates enormous data, and from the data, it can give us an ambulatory glucose profile, and from the AGP, we get important metrics: time in range, typically between 70 to 180 milligrams per deciliter, time below range at different thresholds, and time above range. And target ranges are now established. So for most patients with type 1 and type 2 diabetes, time in range should be over 70%, and time below range, depending on the range and on the threshold, less than 4% and less than 1% respectively. But these targets change in particular groups. For example, in the older age, it is acceptable to have the time in range above 50% rather than above 70%, and time below range needs to be much, much less than 1%. And this kind of more lax treatment target is quite relevant to fasting during Ramadan for people with diabetes. CGM is a behavior modification tool, and this concept is now very well established. Here is an example from a case series, and in this particular case series, what they did, which is something that perhaps we could do in future studies during Ramadan, is using blinded CGM for 10 days in patients, and this is one particular patient, and then repeating the CGM unblinded later on. So you can see here with blinded CGM on the left that the AGP really looks pretty miserable, with time in range really quite unacceptable. And after unblinding, your time in range increases really quite enormously. And you can see that the fluctuations are much less and the AGP looks much more beautiful. But this is one particular patient, and we know that not all patients are the same. This is another patient in panel A after 10 days of blinded CGM. And just look at the time in range of 47%. And then in panel B, we have the same patient after 2 weeks of unblinding and empowering the patient with the ability to see what is happening to the blood glucose. And you can see that the timing range changes from 47% to 94%. And finally, in panel C, you can see the same patient who stopped using unblinded CGM 6 months later. The figures look pretty bad again, with 51% time in range. Just struggling, right? Okay, here. So let's talk about some indirect evidence that CGM can make a difference in Ramadan. And already there is plenty of evidence for this. Evidence in that CGM is making a huge impact by generating data and improving our understanding. And this is one particular example from our group some years back, which showed that Ramadan fasting is safe in the majority of patients, but in some patients things get a little bit worse, and in some patients they get better. But this kind of study is only possible through the data that continuous glucose monitoring gives us. Another way of doing this is by comparing outcomes in non-CGM studies versus CGM studies. I've already shown you non-CGM studies such as EpiDian and also the Dark Global Survey, looking at selected CGM studies. And this is from one that we did and was published in 2021. You can see from the title of the paper that patients looked at here were those treated with insulin, type 1 diabetes, or patients with type 2 diabetes, but on insulin. So a high-risk group. The number of subjects in the study was 40, not huge, but still a lot of data was generated and enabled us to come up with some important conclusions. HbA1c at the beginning, before Ramadan, was 7.9%. So not too bad in terms of initial glycemic control, but not perfect. But what I wanted to show you from this study is that time below range, less than 70 and less than 54, was 2.1% and 1.3%, overall 3.4% during Ramadan. So this is time in hypoglycemia. And compare that to pre-Ramadan. So in fact, you can see there that compared to pre-Ramadan, time in hypoglycemia, time below range, paradoxically reduced during Ramadan. So contrast that with the non-CGM studies, the older studies, where hypoglycemia increased several fold. But here, in fact, It is not increasing several-fold, although this is a study, it's a controlled group of patients. Nevertheless, you can see in patients who are using CGM, the hypoglycemia risk is not increasing, although still is significant. As for hyperglycemia, you can see, as you would expect, hyperglycemia increases, but again, this is not several-fold, as you can see in non-CGM studies. So here is an indirect evidence that using CGM reduces risk of hypoglycemia and hyperglycemia and can make things better. Here's another study from our colleagues in Qatar. A nice study, it's a ProFast3, and amongst other things, they looked at CGM metrics, and here is just a summary, and just compare the two columns before Ramadan and after Ramadan, and what you can see here is that in fact your time in range does not negatively change during Ramadan fasting. Your time in range, in fact, in this particular study, increases and certainly does not decrease several-fold, or does not decrease as older non-CGM studies would make you expect. Of course, in non-CGM studies, you don't have luxury of having these data, and that's another important thing about using CGM. DAR conducted a physician survey last year, asking many questions from the participants. 105 physicians responded to this particular question. In your practice, what percentage of fasting patients use CGM for glycemic control during Ramadan? And you can see 66.7% of physicians responded, saying that less than 25% of their patients were using CGM in Ramadan. Still not a high proportion, but it just makes us put things in perspective. In the same survey, physicians were asked, should glycemic metrics guide advice on whether patients should fast during Ramadan? And you can see in the green column, the answer was yes, particularly for patients on insulin. The answer was yes in 46.7% of physician participants, and 38% thought yes for all patients. CGM metrics should be guiding advice on whether patients should be fasting during Ramadan. Direct evidence, though, will not be easy to generate, and there are several provisos for planning such a study that I will not have time to go into right now. And at that point, I just want to summarize what I have gone through. CGM is a well-established behavior modification tool. CGM-based studies have transformed our understanding of glycemic changes during Ramadan fasting. Hyper and hypoglycemia are major issues. No direct evidence on how much of a difference CGM is making in patients' outcomes during Ramadan fasting. And finally, some direct evidence already exists indicating some indirect evidence rather already exists indicating CGM is making a difference in reducing hyper and hypoglycemia in patients with diabetes during Ramadan fasting. And at that point, I'd like to thank you for your attention, and I hope I will be able to join in order to answer questions if there are any.